When you hear my accent, remember that Toronto is south of St. Paul. If you need to look at that on your phone, it's true. But yeah, so I put this talk together because I thought, we've heard a lot about this long face growth pattern in oral breathing, and I thought, well, gosh, if I'm in charge of like recommending treatment or doing the treatment, I need to know like which way this is going. Did they grow funny because they're breathing funny, or are they breathing funny because they grew funny? And so I really went back to really the classic literature on this, because I think if you tried to get IRB approval for any of these studies anymore, they would laugh you out of the institution. So Dr. Capitan talked about this. This is Scammonn's growth curve, and we get kind of two bumps, and the first bump kind of corresponds with the neural growth curve. The second bump corresponds with the puberal growth curve. And if you look at growth of the upper and lower jaws along with that, you can see that the upper jaw is really growing as the neural growth curve is happening. Lower jaw is also getting a bump with adolescence. And so as an orthodontist, I'm looking also at the teeth, and I think, well, I'm not going to treat anything in the primary dentition, so I kind of wait for the transitional dentition to really start thinking about treatment. Oh, let me go back one. So if there's anything that's happening with the maxilla that I need to try and affect the growth on, I really need to be looking at that before 10 years of age, versus mandible, I really want to be waiting for that until adolescent growth spurt. So what's determining our growth? Someday I'm going to have a painting of me with a pipe like this, but this is Moss, who said bones don't grow, they are grown, and I really like that. So he had this functional matrix theory, which is all of these things. But to me, the most interesting thing about this...
We want to hear that Toronto accent.
Yeah, hello. I got long A's. I used to say, let me get my bag. And then make fun of me in residency. So the spaces, to me, was the most interesting part of all of this. And so the functional matrix is the things that are kind of contained within all of this. And so he's got subcategories of all this as well, too. And so the capsular matrix is basically your face. And as your face is growing down and forward, that's pulling all of the bones with it as it comes. So it's moving the positions of the bones in space. That's also moving the position of where all of the bones, cartilages, and tendons are involved. And then if you look again at the kind of the smaller level still, then where's the attachment of these? Dr. Capitan was just talking about this, to the individual pieces of bone, and then how does the periosteum affect the actual shape of the bone? And so I think Moss's theory kind of does this thing, where it all goes around and back to the function part of it, and the function is actually determining the position and the shape of all of these other things. So just to make my life as an orthodontist hard, not only are the bones growing at different times, but they're also growing in different ways. And so we have intramembranous growth in the maxilla. So basically we have a suture that gets stretched apart, that recruits growth hormones, that recruits osteoblasts, and then that grows bone, and then we have more bone. This is happening a lot before age 10, and it's going to start to taper off. The reason is we're going to start to interdigitate our suture, and the more and more fusion we have, the less and less growth we have. Versus growth in the mandible happening in the condyle, where there's cartilage. We have the cartilaginous model that's going to get replaced by bone. Sorry, I clicked the button one too many times. So again, a totally different growth mechanism that's responding to growth hormones rather than kind of a mechanical pull of the suture. So again, what's happening? The neural growth, so as the brain enlarges, it's going to push the maxilla down and forward. That's going to separate the cranial base sutures and lead to increased growth of the maxilla and pushing the maxilla down and forward. And then again, soft tissue pull of the face down and forward is going to distract both the maxilla and the mandible. In the maxilla, that's opening our sutures so we can grow new bone within the suture itself. In the mandible, it's distracting the condyle out of the glenoid fossa here. And then that cartilage is going to respond to growth hormones and grow up and backwards back into the fossa, basically. So again, kind of the third level of complexity to this is as that condyle is growing, it can also grow in different directions. Yay for the orthodontist to figure this out. So this is Bjork. This is my favorite study. This is the one I always think of, the IRB. So he would take these little metal pins and put them in this plunger device. And then you would go in and he would hold it and somebody would hammer those pins into your bone. And then apparently you would get a postcard on your birthday saying, happy birthday, come for your x-ray. And he would do serial SAPS and check the growth on this. Lovely, I'm glad he did it so we don't have to do it these days. So one of the main directions of growth is up and forward with the condyle, which is going to rotate the mandible in a forward direction as well. Again, we've got a couple of different things that can happen. One is that the incisors actually are in occlusion, which leads to what we call a good grower or a good growth pattern. Except for when the mandible is too small. Now we don't have incisor contact, so our point of rotation is more in the premolar region. This is going to grow into our class 2 div 2 deep bite patients, short face growers, versus the other kind of growth that can happen is up and back at the condyle, which rotates the mandible down and backwards, with our center of rotation back in the molars and leading to the long face growth pattern. And these guys, we see them in clinic, and it's very like, you can see these people, and you don't even need an x-ray, but it's very pathognomonic for the way that these patients are growing and the things that they have after their growth pattern. So these are kind of a list of the backward rotation. Again, as that mandible is going down and backwards, the tongue comes down, so the maxilla is narrow, the teeth over-erupt, the mouth is open, so we have to have mentalis strain to close the lips. So I love this one too. Harvold took monkeys and he would surgically close their nose, so they had to be mouth breathers. And then the monkeys did one of two things with their respirations. One group of monkeys would open and close with every respiration pattern. The other group of monkeys opened their mouth and stuck their tongue out and just stayed that way. Do you want to guess which ones grew funny or didn't grow funny? The open mouth, tongue forward posture led to long face growth patterns. Linda Aronson then looked at this population in kids with adenoid hypertrophy, which is basically causing nasal obstruction and obligatory oral breathing patterns, and all had the same look with the droopy, tired eyes, long face, open mouth, tongue forward posture, and found basically the same thing that we found in all of the monkeys, which is basically all of the same things that Bjork found in his backward rotators. I thought this part was interesting too. After adenoid removal, some patients responded well to that treatment and others did not. And so I thought about that with the mouth or lip taping question. Sometimes it might help and sometimes it might not for most things. So my sad monkey. So which came first? I don't know if it's chicken or egg, but I think that this is probably, looking back at the kind of traditional growth studies, how it goes is that individuals have airway needs. That changes their respiratory pattern, which we need the space of the pharynx to actually function, which is going to determine where our skeleton and muscles are, which is going to determine our pattern of growth. What do you guys think? Chicken, egg? So again, the question becomes then, where do we act for treatment? So I just want to wrap up. I'm watching the band because I've got to sit in with the band in a few minutes, you guys. So I just want to wrap up some treatments. These are my mentors. Larry Andrews is my guy, the 6 keys to naturally occurring optimal occlusion and 6 elements of oral facial harmony. I haven't found anything better than this. So I learned it from Dr. Hallman, who was my program director in DC, Dr. Tremont, who is now the chair at MUSC. Dr. Abid was our oral surgeon, and then Jeff Posnick, fellow Minnesotan oral surgeon, plastic surgeon. His private office was in Dr. Hallman's building where she had her private office. So somehow she convinced him to just let us come as residents, and we'd just sit in Dr. Posnick's office and he'd show us cases, and it was pretty awesome. So I think one place to intervene, we've heard a lot about soft tissue today. You don't want me as the orthodontist touching any of these structures, so that's for ENT and oral surgery to take care of. I think my place is way over here at the hard tissue part of it. So, and we talked a little about extraction today, and being the last speaker is always hard because I don't want to what if I disagreed with everybody? And I totally agreed with what everybody said. And I'm with Alex. I love a systematic review too. This paper looked at 70 articles and found 7 that they thought had decent science. And I always think, what happened when they read the other 63? If somebody's really following those things, But what they said is if you take out teeth, if you take out a tooth and retract the incisors all of the way, that could decrease the airway, the oral volume. That's the hardest thing for me to do as an orthodontist. I've tried that. I need Dr. Capitan to put some skeletal screws in the back so I can anchor it to the skeleton and not to other teeth. Because what really happens when we close space is it's tug of war, and I get mesial movement of the molars, which they said tends to increase the upper airway dimension. And none of these studies actually did a functional assessment of the breathing. So evidence was still out according to that systematic review. This was a health partner study. I like this one because it's a big, at least population size, where they looked at 2,800 patients with an extraction in each quadrant, assuming that those were orthodontic patients because they looked at all this, post-record review, versus people with no extractions. Their incidence of OSA in these two population groups was exactly the same. I agree with Alex. I don't think this is an extraction thing. My personal opinion is, why do we pull out teeth? Because it's too crowded. We can't fit the teeth within the bone. So we take out the teeth take out teeth to align everything else in the bone. But we haven't addressed the bone is too small. And so this is probably a skeletal issue that we're not addressing. We're taking out teeth to do our job to align them in the bone. But I think we need to take it one step further if the bone is too small, because I do think that's a place where we can intervene. So AP, this is a Dr. Andrews thing, that where the upper incisors should be actually has a relationship to the forehead. And this was kind of an eye-opener for me because Dr. Posnick and Dr. Obeid both said that this had changed how they had treatment planned their surgery by trying to target kind of glabella vertical, or the front of the forehead, as the place where the incisors should be. This is a patient of mine. They drove from Michigan to see me in Minnesota. And mom said, I don't want to have jaw surgery. We drove here because I was working for Mayo at the time. We drove to Mayo Clinic because we don't want to have jaw surgery, so do anything you can without jaw surgery. The nice thing I like about the forehead thing is you can just have your patient smile. You don't need to do anything else. And then I could have mom look at her and we could talk about where the teeth should be relative to where her face was. And so it makes my consultation a little bit easier, especially when it's kind of, it gets shut down right away from that. She was also so mom didn't want to have surgery. She's a theater kid and had stopped trying out for plays because she was embarrassed of the way she looked. And so we talked about the benefits of jaw surgery. And if I can do my job as an orthodontist and put the teeth in the bone, and the surgeon can put the teeth together in relation to the face, you can really have life-changing alterations here. And if the hard tissue here is in the right place, the soft tissue is going to be in the right place. So then I was looking at, okay, if I want to do facial landmarks, we love to measure CEFs as orthodontists. How does that relate to a CEF measurement? The short answer is it doesn't relate at all when I looked at both SNA, SNB versus these facial landmarks. For the upper jaw, the facial landmark said that the upper jaw could go forward a little over half the time compared to the skeletal landmark. But in the lower jaw, 80% of the time, the facial landmark said that the jaw should be farther forward than what the CEF said. So then I thought, okay, if I'm going to incorporate a facial landmark into my treatment planning, we have class 1, 2, class 3, but that doesn't really tell me enough because there can be different kinds of class 1, class 2, class 3. So if you look at the relation of the jaws to each other and then add the component of looking at the relationship of the jaws to the face, we can get a different answer. So I wrote this paper and I got it in JOMS and I really like it because this really helps me determine what I'm going to do for treatment planning. So for like class 1, there's 3 different kinds of class 1s. We can be in a good relationship in an AP dimension. We can be too deficient. We can be too excessive. Class 2, class 3 actually has 5 different relationships where the upper jaw can be in an okay place or like both jaws can be deficient, both jaws can be excessive. The mandible can be in a good place, or they can be on totally opposite sides of the field for us. What I liked about doing this is when we look at maxillary deficiency in the AP, and mandibular deficiency in the AP dimension, it really identifies 5 different kinds of deficiencies, both in the upper jaw and in the lower jaw. One of my residents did a study just trying to determine how many of these we saw. This was in a Minnesota population, so heavily Scandinavian, but most of our patients there were deficient, either class 1 deficient or class 2 deficient. So how do we treat these things? This is the orthopedic part of being an orthodontist. So if I want to try and get the maxilla to grow forward, we use something called a reverse pull headgear. So here the traction is based on the front of the head or the front of the face. And so the child wears this at night when they're sleeping, and what I'm doing is distracting those maxillary sutures and trying to increase the volume of bone that I have. Unfortunately, nasal CPAP is not anchored to the front of the head, but to the back of the head. And this is actually the treatment this is the traditional headgear treatment that luckily we don't do this very often. Really it would be used in like a maxillary excess situation where we're restraining or compressing the sutures as the face grows to hold the growth back of the maxilla. And I wouldn't really want to do this in a normal growing maxilla because now I've created a small jaw where I didn't have one before. So Dr. Posnick one time was talking about cleft and was like, if you would just let a cleft kid grow until they're a teenager, if you look at unrepaired clefts, they actually grow really well, except they have trouble eating and swallowing and talking and breathing. So we need to do these interventions in order to treat the functional needs for the patient, and then we deal with the growth aspects later. And I would agree with that with the nasal CPAP as well too. Like you need to treat the function, deal with the growth effects afterwards. So I gave that one a thumbs down. Mandibular deficiency. This is a broad category of appliances called mandibular anterior repositioning appliances. It's basically something that goes between the teeth, and when you try and close together, it's going to position the lower jaw forward. Again, what we're really trying to do is distract that condyle out of the fossa, and so we can get the growth to be directed in the right direction. Does this work? It's a little questionable. I tried to find a study that would tell me if this would work or how I could determine what my rate of success will be. I did find a SAPS study that looked at all these different SAPS measurements. The only one that seemed to have a correlation with treatment success was this mandibular angle measurement. And if the angle was less than 120 degrees, the chance of success of this treatment was higher. The problem with that for us, when we talk about airway, is that's not our backward rotator long face patients, it's our forward rotator short face patients. So it can work in a certain population, but not in the ones that we're worried about breathing with. Really, I think the best way to treat that long face is plates and screws and a good old counterclockwise rotation. Maxillary transverse, again, this is another Dr. Andrews topic that I'm pretty passionate about. So he says we can't change the shape of the basilar bone of the mandible, and I agree with that. If you've ever tried to make a denture, I was a general dentist for 14 years. I tried to make dentures on these and it doesn't work, but that's basically the bone that's left after the alveolus is gone. So he uses the mucogingival junction to define the shape of what the mandible basilar bone is. Once we know what that is, then I can determine, what my lower arch form should be and where I should put the teeth within the bone. Once I know the lower arch form, I want the upper arch form to be slightly bigger than that. And then finally, I can look at the shape of my maxilla and say, can I intervene on the maxillary shape? Generally, we're looking at either 2-piece, 3-piece upper jaw surgery or expansion for growing patients. So I'm using these anatomic boundaries to determine where my teeth should be. And typically we like to see that kind of we call it dark buccal corridors, that the teeth kind of fill in the smile all the way out to the corners of the lid. But you can see for him, it's just empty space. There's not jawbone for the teeth to be there. But if I can give him expansion, now I can get both an aesthetic smile and put the teeth into the bone where they both match upper and lower. And you can see I've got posterior teeth in bone back there, which again, the dentist in me thinks teeth should live in bone. Otherwise, you take them home in the little tooth chest that you give to your patients at the end of your appointment. So again, I was a regular dentist for a long time, and I thought, well, if they don't have a crossbite, then they probably don't have a transverse problem. But if I look at it through Dr. Andrews' lens, if I'm looking at where the mucogingival junction is and the shape of the lower jawbone, you can see I just have all this bone on the buccal shelf. And that's just free bone, and as an orthodontist, I just love nothing more than free bone that I can put teeth into, because so everything is tipped lingually And if I'm using the shape of the lower jawbone, I'm going to tip all those teeth out, and that's how I'm going to resolve my lower crowding. But if I do that, then I'm going to have a transverse problem in the top if I tip those lower teeth out. So now if I look at how wide the lower jaw is and compare it to the width of the upper jaw, now I can start to see where I've got a discrepancy. And I should try and publish this paper again, but I measured 105 patients, and of those, only 12 would I do an expander on, versus when I tipped the molars out to Dr. Andrews' basal bone landmark, I would have expanded 53 of those, which was a huge difference. The other thing that I looked at was all of the unilateral, bilateral crossbite patients needed expanders. But when you looked at the no crossbite patients, almost half of those patients would have benefited from an expander had I been using the anatomic boundaries to determine where my teeth should go. So I think in almost half the patients, we could be masking transverse discrepancies by the tipping of the lower teeth. Alex did a really good job of covering some of the literature. I'm not going to cover this too much, but I do like this, as we expand, the tongue raises to the roof of the mouth. I think that's a big benefit. But the question that we don't answer with all of these studies is, why did we expand? What was the source of the inflammation? And I think that's kind of a missing piece of this. Finally, the vertical, this is my last thing. I should have put in my little table of contents happy hour at the end of my thing. So with forward rotators, again, the way I kind of look at this is like that mandibular plane is just shooting out the back of the neck. The way that traditionally orthopedics has tried to deal with this is to do a low pull or cervical pull headgear that would kind of pull the maxilla down, which would in turn rotate the mandible backwards. And vice versa for a backward rotating patient where the mandibular plane is shooting up through the top of the head, you would do a high pull headgear and try and hold the maxilla up so the mandible then could rotate farther forward. I think this is what's happening in our cleft kids when they've got that class 3 tendency, because that maxilla is just not growing vertically at all and everybody's just rotating farther forward and you get that mandibular prognathysm. I don't know. There's a lot of side effects to these. I don't know that I would choose any of these for treatment. Another thing we talked about though too is I think I can affect AP maxilla pretty well, but I have a limit. The research says about 2 to 4 millimeters is really all I can expect out of orthopedic treatment, much different than the centimeter that the surgeons are going to advance them if we're doing MMA for OSA. Mandible, questionable, especially in a backward rotator. Transverse, I think we can expand a lot. I've had syndromic kids where I've done a 12 millimeter expander and then taken it out and done another expander. So we can really affect the transverse. Vertical, I'm not sure on that one. So again, I think really this is kind of treatment of the cause when we can actually open the airway. I, as an orthodontist, I think I'm over here treating the effects of the growth at the end of the day. The introvert's way of networking is to put your phone number up so you don't have to talk to everybody. Just say, here, this is me. And that's a QR code if you want to give me any feedback too. That's it. Thanks, everybody.